Okay. All right, thank you all for joining this webinar today. This is the fifth, I should say, in an interdisciplinary series sponsored by the Johns Hopkins Modeling and Policy Hub. My name is Kate Grabowski, and I co-chair these webinars along with Dr. Dan Polsky and Mario Mesus at the Carey Business School. This webinar series aims to bring researchers with infectious disease epidemiology, policy, and economic expertise in the same room to discuss important topics relevant to COVID-19 control and to facilitate crosstalk across disciplines with the ultimate goal of improving public health. So today we're going to be discussing a highly contentious topic, lockdowns for COVID-19 control, as well as the economic and social implications that go along with them. As the summer ends and the fall and winter months are upon us, I think we're all concerned that COVID-19 cases are going to begin to rise as we all move indoors. And so with no vaccine or effective antiviral treatments, we're really left with just non-pharmaceutical interventions right now. And that includes things like test and trace, masks, social distancing, and also lockdowns like we'll discuss today. So joining us for today's discussion are experts in infectious disease dynamic modeling and epidemiology, economics, human rights, and implementation science. I would first like to welcome our main speaker, Dr. Meagan Fitzpatrick. Meagan, can you give us a wave? Hi, Meagan. All right, so Dr. Fitzpatrick is an assistant professor at the Maryland School of Medicine, where she is faculty in the Center for Vaccine Development and Global Health. She is an infectious disease transmission modeler who applies models to assess disease control strategies with a particular focus on evaluating the cost effectiveness of vaccines. Her research combines methods from economics and decision sciences with epidemiological models to provide policy recommendations and support evidence-based decision-making. You may have seen Dr. Fitzpatrick's work in the news this year. Her recent study on Medicare for All in the Lancet was touted by none other than Bernie Sanders in the Democratic primary debates. I think a first for epidemiology in the news at that time, although we're now in the news quite a bit. On a personal note, Meagan and I go way back as colleagues. Meagan started her career off at Hopkins after graduating from Notre Dame as a technician, working in Joe Martlick's lab with the multi-centered AIDS cohort study, where I also used to work as a technician on Friday nights. I did not have much of a social life at that time. So today, Meagan will present her work examining the interplay between COVID-19 control, using social distancing and lockdown measures, and the economy. Her research embodies the type of interdisciplinary work that this webinar series aims to encourage and that we should all strive towards. Also joining the conversation with Meagan today are two discussants, Dr. Zoe McLaren and Dr. Steph Baral. Dr. McLaren is an associate professor at the School of Policy at the University of Maryland, Baltimore County. Her research interests include estimating the impact of access to health resources on economic outcomes, tuberculosis, and causes of high unemployment in low-income countries. Dr. Baral is an associate professor here in the Department of Epidemiology at Johns Hopkins, and he's an expert in infectious disease dynamics and implementation science. Steph acts as the director of the Key Populations Program at the Center for Public Health and Human Rights, and so we'll bring a unique perspective from that domain. So welcome, Zoe and Steph, and thank you for rounding out this Maryland trifecta that we have here today. And also thank you to all of us, to all of you in the audience for joining us here today. You'll see you have a chat box and a Q&A. I believe there's a Q&A box as well. So if you have questions for the end of the conversation today, please feel free to post them in the Q&A. You can use the chat to have some general discussion as well, and to tell us a little bit about yourselves and why you may have joined here today. So feel free to use that function as well. And again, we'll have questions at the end as well. So if you can't think of anything immediately or as the session is going on, but you have something to say at the end, please just post those questions in the Q&A. So without further ado, I'm going to turn the floor over to our main speaker, Dr. Fitzpatrick, and she's going to take it away from here. So thanks for joining us, Meagan.
All right, can you all see my screen and hear me? Yeah? Sorry?
I didn't know if we could hear you there. Okay, but now we can. Great.
Okay, all right,
go ahead.
Great. So thank you so much for this invitation. I'm really excited to discuss this work with an interdisciplinary group, and I'm very excited to get your feedback about it. So I think starting off, I'd be remiss if I didn't acknowledge that this work is not mine alone and that I have been working with a fantastic team with Scott Sheffield from MIT and with a group of students and postdocs from the London School as well as Harvard and Yale. So Scott Sheffield, Anna York, Nicole Smartwood, Alyssa Belinsky, and Annie Williamson. I hope several of them are on the line as well and able to take questions if you have them at the end of the discussion. So I'd like to give a slight modification to the title that was distributed. So the title here is Strict May Be More Efficient, an Intermittent Reset Strategy for Long-Term Management of COVID-19. And so the context here is what Katie set out, which is that COVID-19 has prompted a variety of restrictions on movement and economic activity. And these restrictions have the goal, of course, of reducing the number of infections and fatalities and serious events associated with the SARS-CoV-2 infection. And these mitigation efforts have ranged from very strict, such as lockdown and shelter-in-place policies, to less, such as changes in indoor capacity limits. So saying, for instance, that a restaurant, instead of having 20 people in a particular seating area, could only have 10, as well as some masking regulations. I mean, these are all things you're familiar with. I think I don't need to go through every non-pharmaceutical intervention that is being put in place these days. So, and we're primarily trying to look at the kinds of restrictions that have an impact on economic activity. And so to a large degree, when throughout this presentation, we're going to be talking about very strict or less strict. It's usually not about what sort of adherence you're getting from your masking policy, but about what sort of activity is being restricted. Is travel being restricted? Are certain kinds of businesses closed? Are schools being closed? Even are there restrictions on the number of people who can be accessing an economic service at any particular time, accessing a service at some particular time? And so we can consider, again, a range from very strict to less strict. Understanding, of course, that these intersect with other non-pharmaceutical interventions, which businesses and governments have adopted. So for instance, these NPI, again, are some you're familiar with, masking or enhanced sanitation or physical distancing. But these things are not operating alone. And I want to talk a little bit about the way that our concept of our goal has evolved since the beginning of the pandemic. Again, something I'm sure everyone on this call is aware of, that the immediate need at the beginning of the pandemic was to flatten the curve, right? We looked at what was unfolding in Italy and what had unfolded in Wuhan and what was happening in New York City, and recognized the emergency situation that arises when you have an overwhelmed hospital system. And so I want to stress in this presentation that we are not talking about that at no point are we ever going to advocate for strategies that involve an overwhelmed hospital system, and that we're assuming that we're operating in a space where we're going to stay below the capacity of the hospital system in all situations. And so that the immediate focus was on flattening the curve to stay below the danger zone of collapse of the healthcare system. And longer term, we ask, what is the best way to stay flat, right? So now that we have, in most places, and I would say, argue here in Maryland, we've achieved the goal of flattening the curve. How do you stay below? What is the best way to think about staying below that hospital capacity limit? And so one option is the happy medium option, right? That we should think of that hospital capacity constraint as a limit that under no circumstances should we cross. And maybe it's not exactly perfect 100% hospital capacity. Maybe it's 80% of the ICU beds being occupied. But whatever the societally accepted limit might be, should we stay? The thought is that if we could just reopen to be immediately below that line and then maintain there at an infection reproduction rate that stays just skimming below that line, that would maybe give us optimal utility, right? Maybe that would be that we'd be the most open that we could possibly be all the time while staying below those limits. And so that is what we're going to call consistent moderation. And as a team of epidemiologists and economists jointly, we wondered if actually the happy medium was in fact so happy, and that it seemed to us that it may not be true that you would want to stay at this consistently moderate level of transmission the whole time. And that in fact, it might be preferable to consider situations in which you have time-limited periods of very strict measures that alternate with periods of being more open. And so one way of thinking about this that is very personal to me is that I, of course, live in Maryland, as my introduction and my background would suggest. And here we are in a space where we are not currently exceeding our hospital capacity limits, but there are still many things which are closed, and including one closure which is personally affects me, which is the closure of public schools across most of the state. And so this consistent moderation perhaps requires schools to be closed, or at least in a situation where many people do not feel it's safe or practical or feasible to reopen, despite the fact that there's considerable economic activity in other sectors. Whereas an intermittent reset would be a situation in which you would have strict closures in which very little operates for a period of time, alternating with periods perhaps being more open. Not perhaps, in this model in which they are more open. And so our research approach was to look directly at these two different strategies. And so we developed a very simple transmission model. I'm not going to actually talk about the model and its parameters, although I'm willing to, it's in a preprint on medRxiv, and I'm willing to talk about those parameters with people later if they would wish. And so a very simple FEIR model, and then simulate periods of consistent moderation, or that should actually be an or intermittent reset. And then evaluate the outcomes both in terms of the number of cases over time, or in this case, the number of infections that occur over time, and as well as the utility or the productive activity that's being allowed to occur at that time, across that same time period, under these two conditions. So the epidemiological structure, we set two bounds on the incidence limit. And I think this will be more clear when I actually show the results, but I'll try to speak through it at first and give the context. So so we consider that there are two bounds on the incidence. And so one bound is what we say the upper limit, which would be, in this case, the hospital capacity limit. And this 1 per 1,000 population prevalence corresponds to what the American Hospital Association says is roughly the place where is roughly the level of community prevalence where hospital capacity begins to be exceeded. Definitely a sensitivity analysis is and should be done on what that limit is in particular places, but follow me through to the base case and we'll take a look at that. And so the lower bound on this is 1 per 100,000 population, by which we mean for for these strategies, we assume that once you get to 1 per 100,000 population, that is the point at which you would begin to reopen. So in the situation of consistent moderation, the prevalence is maintained at 1 per 1,000 population throughout the entire simulation. And at the lower bound, it oscillates between that upper limit and the lower limit with varying degrees of suppression or restriction at any given moment. And that reduction in transmission, which can bring you from the upper bound to the lower bound, is the parameter value that controls that is C. And so we will be varying C across a few different simulations to see how milder restrictions versus stricter restrictions might intersect here. And then we also attach a utility function. So for a particular value of C at a particular time, we can think of the utility function as falling roughly into these 3 different shapes, right? And what I'll show you is across the range, is across a wider range. But here, if we try to just think a little bit about what these shapes are and what they might mean. And this is where I'm sure that some economists on the call will correct me and feel free to discuss in the discussion section, but I'll give you a little bit of our perspective on how these operate with and how these connect to the real world. So first we can think of utility functions which are convex, in which we think that alpha so first of all, we formalize the utility function as an exponential of C, such that C to the alpha is our utility function, but that we consider ranges of alpha with different implications. I should have made that more clear at the outset, but I hope you can see that here from the equations. And when alpha is greater than 1, we can think of that as a convex function for the utility. And so what this means is that when the utility function is convex, it means that canceling some activities has not very much effect, but only when you start to cancel things in tandem do you get higher returns. And so in this case, it might be, for instance, the way that you might cancel some activities in a particular cluster of individuals, but if their second set of activities are maintained, then there's still transmission potential in that network. And so you're not, in fact, breaking up the network, but you're only perhaps slightly modifying their interaction time. And so that would give you, so if that were true, then the first activities, your first attempts to decrease C result in less impact than your later attempts or your later restrictions. A more moderate utility function would be one in which every activity has a more similar impact. And so in this case, you might think that, for instance, if you thought that the entirety of our utility and our economic activity existed of firms of more or less the same size, which we know they don't and they aren't, but follow the hypothetical of roughly the same size, and that canceling a certain number of them reduces both the amount of transmission directly proportional to the number of closures that you had, then you might assume that alpha equals exactly 1, and you would be in a fairly moderate zone for the utility function, where alpha equals 1, and so your utility equals your C, your dampening effect, or your effect on utility is equivalent to C. And then the other thought about this is that you could exist in the zone of ultra-concave functions, where you think that actually you have some things where canceling your first activities, you can cancel some immediate things that yield high returns, and then canceling things later yield lower returns. And this, to some degree, has some connection to reality in what we think about schools and universities, where we identify particular high-risk activities, or for instance, when we think about concerts, other mass gatherings, that canceling those can yield very high returns, as we believe and as we see, and then canceling later activities have proportionately less effect on the transmission of COVID-19. And so this is the space. So we consider this fairly wide space. And I'll show these results and leave it to you to decide where we might exist in this space. So here are the results, and I'll walk you through these figures right here. So for figures A, B, and C, oh wait, I'll make sure, can you see my arrow? So for figures A, B, and C, what we see here is that in all of these figures, on the y-axis, we have the number of infections, or rather the prevalence in the population, not the number of infections, the prevalence in the population. And then on the x-axis, we have over time in weeks. And in all of these figures, you'll see a constant orange line, and that constant orange line is the consistent moderation strategy, which, as we stipulated, would give you a perfectly constant level of economic activity, but also level of prevalence of infection over the time period. And as a comparison, we have 3 different cycles, so to speak, of economic activity, and 3 different cycles of C, in which we vary both are effective, so we vary the suppression method, and we also vary the are effective under release. So here we see 6 weeks, what we say 6 weeks extreme down, followed by 6 weeks extreme up. So it's a very strict restrictions followed by fairly wide opening varied over this time period. And then here we have 6 weeks of extreme down followed by 18 weeks of milder up. And these are of course designed so that they will at the 8-week period hit the prevalence of constant moderation. And so we see that you can get a lot fewer infections with this strategy. And then over here we have 18 weeks of milder down followed by 16 weeks of extreme up. So if you were not willing to accept the most restrictive policies, but you were still interested in having some more restrictive policies and then opening up for short periods of time, you might choose this strategy. And then here for panel D, we have the corresponding utility curves from each of these 3 panels. And so here on the x-axis is your alpha. So what do you believe that your alpha might be? And here, based on whether you think alpha is closer to 0 or whether alpha is near 1 or up at 2, what is the utility that you get from each of these strategies? And so we can see that actually the strategy of consistent moderation or happy medium in fact provides either equal or lower utility than the comparable strategies across a wide variety of assumptions about the functional form for your utility. And then as you move to higher levels of alpha, then you see that some distance is introduced here. So as you move into and just to rephrase, as you move into an economy in which you think that the first things you might close are the most impactful, and then after that, there's essentially diminishing returns in terms of the impact of second closures on the transmission in your population. As you believe that becomes more extreme, you begin to see that in fact your strict strategy is even more efficient compared to a strategy where alpha equals 1, and you think that you have an equal number of identical firms, or sorry, not equal, and that your society consists of mostly identical firms who can be opened or closed at some fraction with equivalent impact on your overall your overall utility. So as an alternative constraint, which we do not advocate and do not think is, that we do not advocate, but which was an alternative scenario that we were asked about and so therefore investigated. The question was, for an equal number of cumulative infections, for equal cumulative infections, does this flip, right? If you were not instead trying to stay below this level of capacity, but instead you are going to say apples to apples with the cumulative number of infections, how does your utility function shake out? We actually see that, so we see that the overall utility is somewhat smaller than than in the previous figure. And here we have taken and so here, if you set your prevalence and then you allow your strict strategy to be opened and closed, or you allow your strategies to be opened and closed, but with the intention that you are instead allowing larger and larger outbreaks so that your cumulative number of infections is meeting this, constantly moderate level, you get a little bit more distance between you still maintain that the happy medium is provides the least level of utility. And so this has really provided a sort of like a check on the model. And again, I want to be clear that we're not advocating that you suddenly allow your level of infection to exceed your hospital capacity. It's a proof of concept for those of you who are interested in the technicalities. And so the takeaway from this model is that the happy medium may not be so happy. So something I've repeated several times, so I'll say it again and put it in red. The intermittent reset provides equal or higher utility than consistent moderation with equal or lower numbers of infections. And so strict is more efficient. When you need restrictions, you should make them count. Concentrating your restrictions to a shorter period of time when they are in effect and in a coordinated way across your population is more efficient than maintaining restrictions in to a lighter level, but consistently across the period of time. And so this is the end of my presentation, and I'm interested to hear the comments that others may have.
Thank you so much, Meagan. That was wonderful. So I think now we're going to move into Zoe's discussion. So Zoe, if you've been able to share your slides, please take it away.
Thanks, Kate. And I'll post all of this online on Twitter, and hopefully we'll stimulate some discussion on Twitter after this presentation as well. So the paper looks at these trade-offs between being in lockdown and having freedom. And the main question is how much social distancing is optimal over a fixed time frame. So in this case, they've estimated that we have an end point of a vaccine being available when we can stop doing the social distancing. And their results are fairly robust over a pretty wide range of plausible parameter values. So I'm not going to get into the details about the model itself, but it looks fairly robust. So just to recap their main results, on the left, that panel shows the % infected at any point in time over time. And you can see that the blue is that kind of strict lockdown alternating with quite a fair amount of freedom. And that actually produces fewer infections over time and more utility, as you can see on the right. And so the question is, where do we think our alpha value is in terms of our context? I think alpha is probably below 1. So it's kind of worth thinking about how far below 1 alpha actually is, but that might be open to debate. So the main intuition for the results is that lockdowns really work. They starve the virus of hosts and help to reduce prevalence. And so we all learned a lot about exponential growth. We think about exponential growth a lot. The counterpart is exponential decay. So when we go into lockdown, we crush the curve. We reduce the amount of transmission and the number of infections quite quickly, especially early on when the prevalence is high. So we can think about each generation of transmission. So each case that doesn't produce additional cases provides benefits in terms of lower mortality and in terms of more freedom from social distancing while maintaining kind of a max level of total infections or kind of infections at a certain point in time. So I think about these coordinated lockdowns as a pulse of herd immunity. The idea about herd immunity is it brings us these extra benefits by basically starving the virus of hosts. So if we can do that with a lockdown in the middle of a pandemic, we actually reap a lot of benefits from that. So I spent some time thinking about what is the intuition behind these kind of very clear results from the modeling in the paper that makes sense with kind of what we experience on the ground. So the pandemic yo-yo is this idea that when we're trying to aim at a certain level, for example, to not overshoot hospital capacity, we're going to end up overshooting and then undershooting and then overshooting and then undershooting because we don't necessarily have good testing. We don't always know the actual transmission, and it's hard to stay perfectly at that capacity or just below the capacity. So we have the pandemic yo-yo with the lockdowns and with the reset. We also have it with that moderate social distancing strategies. So we can't, it's really not feasible to stay exactly at that horizontal line. We're gonna kind of yo-yo around that. And so you can see on the panel on the left, that top green line, that's exceeding hospital capacity. So we may allow for that we have times when capacity is exceeded, or we may decide to aim for a slightly lower level of infection to make sure that we never actually exceed that hospital capacity, which can be quite stressful on everybody and has a lot of downsides as well. So the way that I think about it is with kind of like surfing. So the idea is that we want to ride the waves of exponential growth and exponential decay instead of trying to fight them. So you can see in the panel on the right that we're surfing. So when the infections rise, that's when we have a lot of freedom. The economy is open. We benefit in terms of utility from having the economy open. We're surfing that exponential growth up to a certain point. But then at some point we need to go into lockdown, and that's that swim part. So swimming is harder than surfing, takes a lot more effort, but we basically focus all of our lockdown energy on reducing the spread. And the extreme version of the lockdown is if everyone's locked down completely for 14 days, then the virus might completely die out. So that's kind of the extreme version of the lockdown, and we're kind of taking advantage of those dynamics here. And then the treading water in the waves, if you've ever tried to do that in the ocean, you know how exhausting it is. And so that's basically never taking advantage of that exponential decay dynamic. And so we end up kind of spending a lot of energy staying at that max level. The trick is that we need to time the switches right. So we need to know when to stop surfing and start swimming, or we're going to exceed hospital capacity. And we also want to know when the lockdown has kind of done what it's needed to do and it's time to start surfing and letting infections rise again. So that's difficult to do without good testing, because we have to have a pretty good sense of the total number of infections in the community to be able to time these lockdowns. It may not make sense to have them preset. It may make sense for them to be adaptive based on the current levels of transmission. So when we think about the real world implementation, we see a lot of modeling. We've seen a lot of modeling in this pandemic, and then we've seen how the modeling really breaks down when we try to kind of implement the lessons in the real world. So what do we want to think about when applying this type of model to the real world? Does it reinforce the main results or does it undermine them? So the main challenge with lockdowns is collective action and coordination. So most people would be willing to do a lockdown if they knew that everyone else is going to be also doing the lockdown, and that would be coordinated so it would have the maximum effect for the shortest amount of lockdown. So if we can overcome that challenge, lockdowns in some ways become much more appealing to the broader population. We also need to make sure that the switches are pretty hard switches. In the modeling, they're hard switches. We go from cowering in our homes under lockdown to having the economy open, going to work, and having a pretty high level of economic activity. So any type of hesitation between those switches eats into the gains. And I think about this as the weekend. So the weekend is a great switching policy, but anybody who has seen kind of work roll over into the weekend, or the weekend roll over into Monday morning, knows how that can eat into the gains. And also with the modeling looks at the rate of transmission rising at the same, so these U shapes are similar. throughout the entire time. But we will learn how to make lockdowns less burdensome. We'll learn how to keep transmission low. We'll get into the habit, and there'll also be lots of innovation over time. So the lockdowns will likely become easier, and the releases will likely become longer. So I've sketched a little bit of that out on the bottom. That left panel is that kind of hesitation or poor coordination. So you don't get that really steep curve where the infections rise again, because some people are kind of slow to switch into that kind of overall open economic activity. And the same way, if they're slow to get back into lockdown when it's time to lock down, then you kind of eat into those gains of this lockdown reset strategy. On the right, you can kind of see that the U shape changes shape over time. So that is kind of the surfing part is less steep over time as we learn about masks and quarantine pods and things like that that help us enjoy economic activity while reducing the transmission. So we want to think about lockdowns as kind of one part of our policy arsenal. There's no one policy silver bullet. We really want to think about using a combination of policies most effectively. So there's a number of complementary policies that can make lockdowns much less burdensome and can also make the freedom, the release from lockdown, much less deadly. So mask wearing, stimulus checks, different types of medical innovation. There's a long list of policies there that can really help support the type of lockdown policy and make people who are very resistant to lockdowns more willing to jump on board with them, especially considering the strength of the modeling in this paper. I also want to mention that widespread testing is really powerful here. So it helps us on that surfing part keep the transmission rates lower because we're able to identify and isolate contagious cases. And it's also really helpful because testing is what tells us when we're getting to that hospital capacity. It tells us the shape of the curve, helps us plan ahead saying, well, it looks like at this pace, we're going to need another lockdown in 2 weeks or 3 weeks or 4 weeks to avoid exceeding hospital capacity. So we want to think about lockdowns as a really useful tool in our pandemic fighting arsenal. And I don't think it makes sense for us to completely discard it. I think it makes sense for us to think really hard about how to incorporate it into our overall policy strategy against COVID-19. Thank you.
I need to unmute and okay. So, and can I confirm folks can see my screen? Okay, great. So, you know, for complementary perspectives, I'm giving this talk, I'm giving it on behalf of like 4 brilliant, actually one's a faculty member, Kate Ruczynski, but Amrita, Naya, and Jean-Olivier, who are all doctoral students in Epi. And so it's called Potential Harms of Regressive Interventions, AKA lockdowns. So I should say this just because I think there's like so often a thing around economics. I own no stocks except for the retirement plan. I'm basically a socialist. And so I just want to sort of put that out there. I believe in universal everything. And so I just, you know, just as an FYI, because sometimes when I talk about this, people are like, you're the economy. And for me, the only thing I care about the economy is in terms of like health insurance and people losing it. So as an outline, I'm going to do this very quickly. I have a few minutes. So I'm going to talk about inequities in COVID-19, acquisition and transmission, inequities in the enforcement of lockdowns, competing health risks, and conclusions. I'm going to do that in a few minutes. So lockdowns in theory are like stay home and save lives. Like lockdowns in practice are like stay home, save lives, and bring me my pizza in less than 30 minutes. Do you know what I mean? Like there are people that have to go out there and serve our needs so that many of us, including me, can work remotely. There are people who deliver groceries and food and all of that. And Amazon's has had a banner year, as we all know. And so I think that, you know, we have this sort of underlying infection that is so like showing us every inequity in our society. And that's not just about universal health care. It is like structural racism, inequities, redlining, all of it. And it's just showing it to us, the effects of it when we don't pay attention to the needs of all. And I think lockdowns just reinforce those disparities because they're regressive. They're not adapted to the needs of individuals. There's also inequities in the enforcement of lockdowns. So the data, and I think some of this will come out soon, show that social distancing violations are really representative of like pre-existing enforcement. So like police are still enforcing the same areas that they always enforce, and those tend to be communities of color. And so there's lots of data, and it's emerging that these, you know, the enforcement of this is incredibly inequitable and kind of structural racism at its worst. people who talk about kind of green zones and red zones, really, because we know the structural inequities have driven these disparities in predominantly communities of color, it feels like it's like sending police to lock down those very communities that have been only affected based on our pre-existing inequities. And so it just feels like this like circular thing where we're protecting the rich at the cost of the poor while still asking them to serve the needs of the rich. So, and then I'm gonna go, then there's like a competing health risk. And I'll just say, it feels very painful when we're gonna do the overall math of like qualities and dollies around these things. But I'll say in terms of NCDs, you know, we've seen substantial disruptions in cancer screening, cardiovascular, and that happened in very short-term dynamics. You know, 40% decrease in cardiac caths, decrease in like the common breast, you know, colon, cervical cancer screening, I'm sure anal cancer screening, although we haven't seen much of it. In the UK, in the Lancet, they showed a 40% reduction in admissions for ACS, acute coronary syndromes, decreases in percutaneous coronary interventions. And then it starts getting to some of the stuff that actually is very difficult to talk about, but is obviously hunger and starvation. Like we've seen massive disruptions in supply chain. Some of the estimates are that it could amount to about 12,000 deaths a day. And obviously that is amongst those most marginalized in Yemen and DRC and Afghanistan, Venezuela and elsewhere. And so, you know, I think you know, it's difficult to talk about. I think it's incredibly important to consider. Amrita Rao has led, you know, we sampled about 10,000 gay men around the world with Hornet. We've seen substantial interruptions to HIV prevention, diagnostic, prevention, treatment services in very short term. And I'll note that there's like a dose response between the increased stringency of those measures and also, you know, the effects of them. So the more stringent you see increases in interruptions in testing, treatment, prevention services, et cetera. And I think, again, just kind of an important thing to consider. For maternal and child health, there's been long-term modeling. And, you know, we know models are what models are, but they've shown substantial increases in under 5 child mortality, increases in maternal mortality, but actual real data have now emerged from Nepal from the lockdown, showing institutional stillbirth rates increased from 14 to 21 per 1,000. Institutional neonatal mortality increased from 13 to 40 per 1,000 live births. And you can see the amount, like the rapid decrease in the amounts of folks presenting to hospital for, you know, for support and delivery. And I realize I'm in a hurry. So I'll say we've also looked at like other things. This was a piece that was led by a series of Iranian colleagues showing incredible amounts of methanol poisoning. BC just released their new data yesterday, showing the third month of incredibly high overdose deaths related to the inability to deliver Narcan and naloxone and outreach services. About 170 deaths per month of young people, 20-year-old folks. And then, you know, kind of COVID-19 linked hunger causing more deaths than the disease itself. So, I mean, I'll just say, like, I think, you know, lockdowns to me represent like regressive and non-adaptive responses to an infection that's defined by its heterogeneity along individual network structural determinants. I think the enforcement of lockdowns represent ongoing structural racism in the face of grave existing issues with police that we've sadly seen just the other day, you know, the very real examples of, and in fact last night. And I think that the lockdowns, I think often we think about them as like, you know, it's like the lockdown versus the economy. And sure, I think of that in terms of like health insurance and people's ability to access prevention, treatment, and services. But it's really about like competing health risks to me in the short, medium, and long term. And I think eventually we're gonna have to do this math, and we're gonna have to understand empirically what were the effects, both positive and negative, in terms of, you know, net qualities gained or net dollies gained and net dollies cost. And I think that's gonna be, it's gonna be hard to look at those numbers when we do. So, yeah, I mean, I think my job wasn't to present path forward. I'd be happy to spend another half an hour about like public health practice responses, adaptive responses, implementation strategies. Wasn't my role today, but it was just to share a little bit about some of the concerns of lockdown implementation. So thanks for your time.
Thank you, Steph, Zoe, and Megan. That very interesting discussion. Lots of different things to discuss here. We have a number of questions in the chat, so I think we should go ahead and start with those. Mari, were you planning to moderate the chat session, or I'm happy to do that? I just didn't want to step on your toes here. Okay, well, in any case, I'll begin with.
Okay. To do that, but I'm happy to help, Kate.
Okay, it's okay, I can do it. I'm looking at the chats right now. So the first question we have is from Amanda Gallant, and she asks, these analyses are very interesting. Have you considered the effect of time delays between infection and measured cases in your analyses? So Meagan, I think this is probably for you.
Yeah, so we did not consider that there would be, so I want to be clear, this is not an optimal control paper saying this is the threshold of detection at which you need to lock down again, right? So we did assume that that people were either aware of their detection limitations or and had otherwise accounted for that in terms of understanding when they might be approaching a particular prevalence, and that the reaction would still happen in time to avoid exceeding hospital capacity. So I think what you're getting at is a very important real world consideration, which is either for the consistent moderation, because as Zoe pointed out, you're actually sort of going at a yo-yo where you have to, hopefully people take the signal that cases are rising and then, you know, take personal restrictions a little bit more seriously, or if it's a kind of coordinated thing that you need to know when you are approaching that threshold. And that if you don't think you do know that, you would want your consistent moderation strategy, you want either of those strategies to be set to a prevalence level lower than that 1 per 1,000 that the American Hospital Association recommends. So you might at that point think that it was only acceptable for your as your trigger to reach you know, 7 per 10,000 instead of 1 per 1,000 or some, and that is something that I think each community would have to look at their own detection abilities and recalibrate accordingly.
Mm-hmm. Okay, and another question, Meagan, was, shouldn't these models take into account that the number of potential hosts decreases with each wave of infection? The waves appear similar, but each subsequent wave should take longer to peak.
Yes, I would say that if you were truly existing on the scale that we are modeling, and you did not have, for instance, either a big initial wave, and if you were keeping these values fairly low, that the effect of the buildup of herd immunity is fairly small. But it's true that if we had simulated, for instance, 25 of these waves over a long period of time, as we were trying to if we thought that the prospects for the appearance of a vaccine were less optimistic, then you would definitely want to take a closer look at what you really think is happening with herd immunity and the duration of protection following natural infection.
So another question is, curious how you modeled cycling of on and off economic effects. Seems like businesses do not go from 0 to 50% back and forth without major operational costs, and many businesses may not be able to withstand cycling anywhere under 100% for long.
Right, so we did it very simply with that utility function. And so if you think that there are costs to switching, then you should adjust where you believe we exist on the utility function accordingly, right? That's, I want to be really clear that I think that a lot of industries have different utility functions, and we tried to think at a fairly straightforward level what that utility function might be, for instance, at the state level. But it is very true that there are some industries which might have that there are industry specific utility functions, and I am probably not qualified to walk through in the next 10 minutes what every single one of those might be. So, but I think with regard to those operational costs, you know, I would hope that some of what Zoe said about learning would apply here as well. this is also true for the consistent moderation, right? So the consistent moderation is not that we all stay completely open all the time, right? That's not what the consistent moderation strategy is. The consistent moderation strategy is we all stay at something less than open all the time. And so when you say many businesses may not be able to withstand cycling anywhere under 100% for long, then those businesses would also be suffering under the consistent moderation. And that in fact, and so it's probably very industry specific as to whether opening and closing of being 100% for 3 weeks versus, versus 33% for 1 week, or sorry, 33% for 3 weeks versus 100% for 1 week and closed for the next 2 is preferable. So I don't know if that, I hope I answered your question technically, even if I didn't give you what the answer was.
I would love to get some thoughts from some of the economists on our panel on this particular topic. So maybe Mario or Dan or Marcella, maybe you have something to add here. Everybody's on mute in case you're trying to talk.
Nothing to add. I thought that was a good answer.
Okay.
Nothing to add from me. I saw that Anna, was a co-author on the study, was trying to say something.
Yeah, Anna made a point in the chat box that I think was helpful. I'm happy to say something about it.
Do you want to maybe say what she said since I don't see it, Steph?
Yeah, I mean, so Anna made a point about not specifically recommending lockdowns per se, but really like, kind of a continuum of strictness of NPIs. And I think, and I'll just say, oh, we can't see the chat. Okay, sorry. Well, there you go. So I think, and it's a longer, more thoughtful comment. Hopefully I did it somewhat justice. So I'll say, I think that's a really important point. So Lindsay Wiley, who some of you may know, maybe not, she's a public health lawyer, wrote this wonderful document about like implementation strategies for social distancing guidelines. And she put out, I think, like 4 kind of criteria that need to be met, which by the way, are consistent with things that DA Henderson talked about 15 years ago. Like, we can do this, but there's a number of preconditions, like, ensuring, like, avoiding undue harm, ensuring equity. Like, these are the kind of preconditions that we need to meet in order to protect folks that are most marginalized from both health issues, in addition to the sort of downstream economic issues with, and so I think that's the exact point. It's a 62-page document, very consistent with lawyers and whatnot, but it has a nice abstract and I can send around. But I think it does a really nice job of like telling us what are some of the things that we need to think about from a legal perspective. There was another question to me about like, it's almost like the Jeffrey Rose argument, I think, from that's been made about like, if we like overall, I don't know, like fluoridate water or something, if everybody benefits, then everybody benefits. And it, like, i.e. like lockdowns will shift the curve over and thus all will eventually benefit from it. And I think, I'm not sure that that's exactly the case. I think actually like these increasing disparities that we're seeing in COVID incidents, and I think we'll learn more about, so few places are reporting race, obviously not by accident, and occupational status and other things that like, I think as we learn to understand what actually happened and the trajectories of this infection, at least I know best in my own backyard, I should say, in the Canadian setting, it is extreme and it's getting worse. And the lockdowns only reinforce those. So I think it's important on the state level or American side, worldwide, to really better understand how these interventions affected overall incidence rates, but especially affected the equity or the distribution of those. So thanks.
Thanks, Steph. Those are all really important points. Meagan, there's another question about some of the earlier work that Imperial had done, looking at kind of these cycling on and off of interventions. And one of our attendees wanted to know, Anton here, wanted to know, how your work kind of compares to that earlier work that Imperial had done on these kind of intermittent
Yeah, I want to
lockdowns.
emphasize that we are far from the only group looking at intermittent lockdown strategies, intermittent cycles in terms of the strictness of policy and how that might work out. We are far from the only group in the optimal control space. As far as we are aware, we're the first group to explicitly tie the utility function to the reduction in transmission, and to tie utility to the reduction in transmission through a function that is conditional on that repression. So I could be wrong, and would certainly be very interested to hear if somebody knows that. So my recollection of the imperial model is that they didn't focus on utility, right? They didn't ask about what the economic or satisfaction or other aspects of the quality of life measures might be. They were focused, very early and very impressively on comparing consistent versus intermittent in terms of their effect on epidemic progression and on the accumulation of recovered individuals in the population.
So one thing I thought that was really important that Steph brought up was this idea of like secondary health impacts. And those are really difficult things to measure. So they often don't get included in the modeling. And like typically what we're just looking at is like COVID infection rates and deaths. And I'm wondering like, how do you, and maybe so you can take a stab at this too, but like, how do we think about incorporating, information on these secondary health outcomes into some of the work that we're doing moving forward?
Yeah, so I'll talk first about this and then about other things that I'm also interested to hear what Zoe has to say, because I found her language to be actually much clearer than mine. She was explaining our own work to me. So when I think about this utility function, I know that I talk a lot about firms, or I talked a lot about businesses being opened or closed or things like that. But I think that utility, when I actually think about utility and what we care about, I actually think about other aspects of life which are fundamental and foundational to our concept of what a useful, good, and valuable existence might be. And so I think that it's really important that we consider, for instance, health, and particularly health maintenance and access to healthcare as part of that. So to the extent that, fully open versus more open versus more restrictive society might have implications for primary care office being more open or more closed, I think that we should consider how that utility function might operate. I would, as a person in public health, I would advocate for primary care offices being more open than other kinds of businesses, just as baseline, right? So, again, these are very simple utility functions that consider, most sectors equivalently. We don't, we did not here say that you should, close pizza shops and but open tapas restaurants, right? Like that's not where we are. And so it doesn't have that kind of granularity. And I definitely think that the criticisms that Stefan gave about what we value, what we keep open, and what we shut down during these lockdowns, having an impact on what our utility function is, that's a really important thing to consider if you move this to a policy sphere, right? So even in our strict measures, not everything is closed. And I happen to think that we as a society should take a really hard look at what else we might have to close to keep primary care physicians open, right? That if that's a thing we value. And this is me being prescriptive in that sense, because I place a high value on keeping healthcare operations open by the nature of being an epidemiologist, right? None of you are surprised by that. And I think as a society, we should have that conversation. What else do, to get to a transmission, which is 1/4 of that at quote, at that consistent moderation. What does that mean? What are we prioritizing? What gets to stay open during the strict periods? That is not decided here, and definitely should be a thoroughly open and transparent discussion. Sorry.
So we're approaching the end of the hour. I just want to leave Zoe and Steph with 2 final thoughts before we conclude for the day. Thank you, Meagan.
Thanks. So I think the logic of does a moderate lockdown versus, or kind of moderate social distancing versus an extreme lockdown, I think that logic also applies to vulnerable groups. So my research area is focused primarily on vulnerable groups and how to protect them. And when we're in the pandemic and there's a lot of fear and a lot of scarcity, it's really hard for vulnerable groups to kind of get what they need to survive. And so that's kind of my main concern here. So when we think about the pandemic, the idea that we can kind of end the pandemic or get it under control, I think is the best way that we can care for vulnerable groups. And if that means doing more intense lockdowns as a way to get out of the pandemic, then I think it's worthwhile. And I think the important thing is to think about how we do these lockdowns. So for example, reducing police enforcement of lockdowns, because public health and criminal justice are not kind of things that really should be working hand in hand. They work in counter purposes in a lot of cases. And I think one good example, we've talked about kind of the economy and businesses, but let's think about public schools, because that's the thing I think we can all agree are very important to everybody, and especially to vulnerable populations. We could imagine a situation where we spent September in quite a kind of strong lockdown. We did it for the schools. So we have strong lockdown in September. It means schools can open in October, see how things work. We've got transmission low enough for that. And then we have a wait and see November. If we can continue to keep transmission low, then schools can stay open in November. If transmission comes back up, then we close in November. But having, putting in the sacrifices in September to be able to open schools in October, our society may decide that that's actually worthwhile. So really thinking carefully about how we do the lockdowns, improving messaging. So the idea that people should not let elective surgeries and elective procedures kind of go by the wayside, that they're safe to do during the pandemic. We just need to be very careful. But primary care offices seem to me to be very safe, much safer than the grocery store. And a lot of people are in the grocery store, but are putting off their primary care appointments. So I think better messaging around kind of the picking and choosing among the social distancing, but this idea that we can do kind of quite strong social distancing still, and that can actually really help us get a hold of the pandemic and allow some of our other kind of testing programs to be more effective once we get transmission down, and allow schools to reopen and things like that. So I think it's worth thinking in the big picture about this moderation versus extreme. If we care about vulnerable populations, it might be that we actually want to advocate for quite strict lockdowns for a short period of time to get the pandemic back under control and minimize the long-term negative effects to vulnerable populations. But that's open for discussion.
And Stefan will give you the final word.
Yeah, thanks. I mean, I think for me, it's really about just really remembering the human element. I have, from a personal perspective, I've been face to face with this infection since March and people affected by it. And I think as it relates to family medicine offices, it's not people not going. All the family docs have closed their offices. Like, they've gone to virtual care only, and it only works for people who have great computer. I mean, there's like, I could list literally like hundreds of downstream elements of me personally sending folks with acute coronary syndrome to the eMERGE only to get COVID tested and discharged. I mean, there's like, when we do the math of this, and now it's like just passionate, like when we do the math of this and we really look at what happened here, it's gonna be horrific. That's all I can say. It's gonna be so ugly, and I think we just need to kind of be aware of that. So that's, I don't know, it's like a passionate closing thought.
And a very depressing one too.
It is
so
what
with that,
is.
enjoy your afternoon. No, I'm kidding. No, I just want to thank all of the panelists for joining us today. Meagan, thank you for sharing your work. It was really interesting, a lot to think about. Zoe, same for you. I think you're right. Like, you gave a really good breakdown of Meagan's models. I liked the drawings on them, so that was very helpful for me. Maybe you guys can share slides. And Steph, yeah, thanks for your perspective. I mean, I think it's a really important one. How we do this and what the other downstream effects are something that I personally think has been overlooked a bit. And yeah, it's a very difficult interplay between all of these different things and how we move forward. So thank you all for joining us here today. We will we'll post this so others who couldn't make it can listen. And if you have any ideas for what these seminars might look like in the future, or you have any recommendations for work we should cover, please feel free to reach out to me or to Dan Polsky. Thanks again and have a wonderful afternoon. Bye-bye, everyone.
Thanks.